Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, and the co-founder, executive vice president, and chief medical officer at the nonprofit CLL Society. And I'm here with a colleague in another wonderful nonprofit. Lee, do you want to introduce yourself, please?
Sure. I'm Lee Greenberger. I'm the Chief Scientific Officer at the Leukemia Lymphoma Society, and I've been heavily involved in following the response to vaccination in blood cancer patients, that is the COVID vaccines in blood cancer patients.
Well, Lee, one of the papers that you were one of the authors on in help with the investigation was titled, and this is a paper from ASH 2022 presented at the recent ASH conference in December in New Orleans, Breakthrough COVID-19 Infections in Patients with Hematological Malignancies during the Omicron, and that's the B1.1529 surge, data from the patient-reported Leukemia Lymphoma Society's National Registry. Can you tell us what your purpose was behind this research, and give us a little bit of background? This built on a couple of other papers that you presented.
Right. So we've been following the response to COVID vaccines in blood cancer patients since the vaccines came online. So we've been looking at this for about the past 2 years. And we found that the background is we found that many patients, particularly those with B-cell malignancies, CLL patients, um, they fail to make anti-spike antibodies. That is, the antibodies that are actually will block the ability of the virus to infect cells, fail to make antibodies in many cases. And then this would presumably put patients at risk of getting a COVID infection, or worse, getting a COVID infection that could land people in the hospital or even die from the COVID infection. Um, so we already knew that. Now, the virus has evolved over time. As we've been studying this, the virus has changed over time, and there have been different strains of the virus. If we roll it back about a year ago, there was a huge spike in this strain called Omicron. This is different than the initial strain that was produced, the so-called Wuhan variant, when the virus was first detected almost 3 years ago. Okay, so the virus is changing. And the question is, if you get a vaccine, will you be protected against these new viral strains? That was the purpose of the study. And we asked this by asking patients in our registry, and I'm going to give you a little bit of your listeners a little bit of a tidbit about what the registry does. Ask patients, did they get a vaccine? We followed this. And then did you get a breakthrough infection, which might tell us how well the vaccines are working in blood cancer patients. Now, we used the LLS registry, which has 12,000 patients in it. And these are all blood cancer patients that we've asked, did you get a vaccine? When did you get it? What type of vaccine? And we have asked, what is the anti-spike level produced in response to the vaccine? These patients have been kind enough to go to the lab, and actually we've been able to analyze this and determine their levels. So we've been
I
able,
was one of them, and I'll just share that CLL Society worked with you and one of your colleagues, Dr. Larry Saltzman, to really push and promote this. And we encourage all CLL patients, and we'll make sure, because the registry is still doing good work, to include a link to the registry when we write up this interview.
well, thank you. So we actually have 2,500 CLL patients in the registry. That's our largest contingent, and I'm sure that you folks through the CLL Society had something to do with that. We've got a really large population. Okay, so Omicron comes along last year, and we wanted to ask who is getting breakthrough infections, how many, and what's the outcome of them. And that was the purpose of the study, to look in that window of time what was happening. What did we find? What we found was that about 10% of the patients have reported, who respond to our survey, and that's about 3,000 patients, about 10% of those patients got breakthrough infections. That means that they had the vaccine and they were getting a breakthrough infection. And right away, that tells us, wow, that's a pretty significant number of patients. Then the question is, who was getting those breakthrough infections and what is the outcome? And no big surprise, because we knew that some of those patients failed to make antibodies. Those were some of the patients that were getting breakthrough infections. So the warning is, wow, if you have got a vaccine and you know you're not making anti-spike antibodies, be careful, particularly now in the case of Omicron a year ago, that you may be susceptible to getting an infection and having a bad outcome. And actually, what we did was, when you actually look across the board and say, okay, who got the infection and what was the anti-spike levels? What you see is actually that the breakthrough infection rate is about the same. That was a little bit surprising and sort of counterintuitive. We said, hey, wait a minute. If you have no antibodies, you should be getting more infections. What I think happened was the people who knew that they had low antibody levels, anti-spike levels, were being very careful and not getting a lot of breakthrough infections, about 10%. On the other hand, patients that had high levels of antibody were going out there and saying, well, I'm well protected. They were also getting about 10% breakthrough infections. So they
And
were thinking,
I'm going to add one thing in here, and I love your analogy. You're not bulletproof if you get the antibodies, but one of the brilliant pieces of your this registry, and when you put it together, was the patient were informed of their antibody levels. So patients would not only you knew at the other end of looking at that data, but the patient themselves would get their results and say, okay, I've got antibodies. And I remember in our support groups, patients would be so excited that they got antibodies or so depressed that they didn't. And you're thinking that maybe that had behavioral impact on what they did.
correct, right? So you said, well, I have high antibody levels. I'm okay to go out, no problem. Of course, the virus was changing over time. We know that that the vaccines have less ability to neutralize Omicron. That is, in a laboratory, you ask, can an infection actually block the ability to infect cells in a laboratory? We knew that was lower. So even if you have high levels of antibody, it doesn't necessarily mean that you're protected against Omicron. And it certainly doesn't mean that you're protected against the new viral strains, which I'll tell you about in a moment. So the message back to patients is, you need to be careful. If you're a blood cancer patient, particularly those with B-cell lymphomas, and you didn't make high antibody levels, you need to be very careful that you might be susceptible to getting infection and having a bad outcome. Now, another piece of information that we found was we could look at about who got breakthrough infections, and we could ask, okay, who got hospitalized? It's one thing to get an infection. It's another one to wind up getting hospitalized. And then we asked, of the patients who got hospitalized, who actually had low antibody levels. And it turns out, when we have small numbers, but when you actually look at the patients who got hospitalized, and we found about 19 patients who did get hospitalized, and we look at who was making antibodies, 7 of those patients had no detectable antibodies, and the other 3 patients that we were able to follow had very low levels of antibodies, which suggests that if you have low level of antibodies, not only are you at risk of getting infection, but you could wind up in a hospital because of the infection. Okay, so it's now January of 2022, and Omicron is tremendous surge. In fact, the surge in blood cancer patients paralleled the surge in the general population. Now we come to a year ahead. Okay, and so the virus has changed again. That's number one. And number two is we have EvaShield, which could theoretically be used to block infections. Okay, so what does EvaShield do? EvaShield is used as a prevention to block infections. This is the monoclonal antibody cocktail that is given to patients, particularly those at risk, to block infections. And it came online about a year ago. I can't exactly remember when. We actually did another survey after the paper that I told you about, to ask who's getting breakthrough infections and have had EvaShield. Because we were asking, well, the virus has changed again. is EvoShield actually preventing infections? We haven't published that data, and I'll tell you, it'll be obvious why in a moment. But we also got about 3,000 patients to respond, about 1,200 patients who had EvoShield, and we could ask, okay, you had EvoShield, who got infections and not? And what you find is about 12% of the patients who got EvoShield had a breakthrough infection. And those that did not get EvoShield, the rate was about 15, 16%. That's not a big difference. And for your audience, I'll tell you that when EvoShield got approved, the difference between those who got EvoShield and those did not get EvoShield was a much bigger difference in terms of prevention. And that was actually the basis for approving EvoShield. So what I'm saying in a nutshell is we already had signs back in August of 2022 that EvoShield was not working as well compared to when it was approved. And about even 10%, 12% of those patients were getting breakthrough infections on EvoShield. Okay, so now roll it ahead to today. The virus has changed again. The strains have changed again. And now there's data generated by numerous laboratories who have actually asked, can EvoShield prevent an infection in the laboratory setting? And the answer is to the latest strains, for those following it, BQ 1.1, XBB 1.5, these are the latest strains. And if your viewers go to the CDC, they can find out what percentage of these strains are. XBB 1.5 is about, as of last week, about 43% of infections around the country. EvoShield in the laboratory has little or no ability to block infections to XBB 1.5. This means that EvoShield, as well as some of the other antibodies that were approved for monoclonal antibody therapy, if you get infected, are no longer useful in terms of controlling XBB 1.5. What does this mean? This means that patients who have blood cancer, who are not responding well to the vaccine, need to be really careful because we have very little in our arsenal to protect against XBB 1.5 and little in our arsenal if you get an infection. Fortunately, Paxlovid, the antivirals, are still effective in controlling or preventing severe outcome if you get XBB 1.5, the current strain, to some extent.
Yeah, and I think that's a clear warning, and there is a lot of depression about the recent data from the CDC and the variant prevalence and the protection offered. At least the projected protection offered by EvoShield is probably in the low single digits now across the country in terms of the variants. And so the messaging that we're doing and the CDC and the FDA is pushing is that it's still worth considering the shot, but understand that the shot is not going to provide a lot of protection. All the monoclonal antibodies are no longer authorized. So we have essentially a limping along pre-exposure prophylaxis, no post-exposure prophylaxis. And we do have some very good antivirals, but not the monoclonal antibodies that were just dramatic often in their benefit to the immunocompromised. We have Paxlovid, and we also have remdesivir, which is quite helpful for patients. But our data suggests that for some patients, it's hard for them to get remdesivir because it's an outpatient. We have molnupiravir, and we know how to handle CLL patients better. So yeah, it's any final thoughts, any things that you want to get across based on your research, and maybe do you have any thoughts about where you're going to go with your research further, because this is quite a database that you put together.
So thank you for that's a very nice summary of what's available. We want to take the registry beyond COVID. We now have 12,000 patients in the registry and are capable of asking patient-reported outcomes, financial situation, ability to work, fatigue, all those type of questions, as well as electronic healthcare records that we've been collecting from about half of these patients, to ask all sorts of questions about patient outcomes on therapies or even watch and wait situation, which we know that a lot of CLL patients are in that situation. That's where we want to go. But we are being very careful to wade into those waters because we want to make sure that the data that's generated from this actually is going to produce something that is meaningful to the community. Even assembling electronic healthcare records is a very, very big task. To do it accurately, and you need a large number to make conclusions from that electronic healthcare data. So we are, instead of a waiting mode to make sure that we have a good project to do, could be even a patient-reported outcome, a study, but we want to make sure that it's going to add something to the existing studies that already have looked at, for example, in the case of CLL patients, what's the amount of atrial fibrillation in a real-world setting? We don't want to ask that question because that question has actually been answered pretty thoroughly.
Yeah. So very excited. I look forward to working with LLS and you and your team. And we'll encourage people like I've done and like a lot of my friends have done, sign up for the registry if you haven't already. And I look forward to more research above and beyond COVID, though COVID is still definitely with us for the immunocompromised. The pandemic is not over. Dr. Greenberger, I'm so grateful for what you and your team are doing, and I look forward to more talks, more communications, and more cooperations.
Well, my pleasure. Thank you.
Bye-bye now.